Now that we've gone through the differential diagnosis for acute dyspnea, it's time to focus on chronic dyspnea. Many of our old friends will make an appearance in this video. We're not through with heart failure or COPD just yet. Whereas acute dyspnea occurs over minutes to days, when you hear the word chronic, think of a time frame of months to years. Patients with chronic dyspnea present with shortness of breath that develops slowly and gradually. A slow, sinking kind of feeling. Nope, even more sinking than just a day at the beach. So we're straight up heading underwater for this one. As always, before we get down to business, let's break down the differential into buckets. Since the vast majority of causes of chronic dyspnea are lung diseases, we'll need a slightly different system than the one you saw in our acute dyspnea DDx sketch. Therefore, let's segment the causes of chronic dyspnea into 4 categories: obstructive lung diseases, restrictive lung diseases, other lung diseases, and cardiovascular causes. We'll start with the obstructive lung diseases. This broad category encompasses processes that obstruct the movement of air out of the lungs. And whenever we say obstructive, just think about this boat of protesters, intent on obstructing the illegal fishing activity here at Blue Bloater Bay. Welp, it looks like one of the protesters has gotten a little too excited and has fallen overboard. Recognize him? He's our recurring sketchy symbol for asthma, embodying airway inflammation and hyperresponsiveness that results in reversible airflow obstruction, hence the reversed pink hat he's wearing. Consider asthma in your patient with chronic dyspnea, especially if they have a history of atopy, such as atopic dermatitis, represented by those red spots on his clothes, and a specific trigger for their symptoms. If you suspect your patient has an obstructive lung disease, like asthma, order spirometry testing, which should show a classic obstructive flow volume loop pattern, represented by that scooped mound of sand hiding underneath the surface of the water. One thing to remember about asthma is that because it's characterized by reversible airflow obstruction, spirometry results may look normal when patients aren't having symptoms. In these cases, we have other tests that can help us make the diagnosis, which we'll talk about in a moment. On spirometry, patients will also have an FEV1 to FVC ratio less than 0.7, a characteristic finding seen in all obstructive lung diseases. Hence the name Spirit o' the 0.7 Cs emblazoned on this obstructive boat. Kind of a small view for a group of Earth lovers. Just saying. So, the spirometer is telling you obstructive lung disease. How do you know which obstructive lung disease it is? Well, give them some albuterol. An obstructive airflow pattern that's reversible with administration of inhaled bronchodilators, represented by a recurring sketchy symbol, the beta-2 tuba, confirms the diagnosis of asthma. Unlike an emphysema, which we'll get to in a moment, the diffusing capacity of the lung for carbon monoxide, aka DLCO, is normal or even elevated in patients with asthma. Carbon monoxide is an odorless, colorless, but very toxic gas, which, at Sketchy, we represent with a colorless, odorless, toxic pile of trash floating by our asthma kid. No wonder you guys are being obstructive. Fight on, you kids. In this scene, if you see plastic trash floating on the surface of the water, think normal DLCO. One test that can be particularly helpful in asthma patients with atypical presentations is bronchoprovocation testing. In this test, patients are given a provocative stimulus such as methacholine, hence our recurring sketchy symbol, the Methacholine Marathon Challenge. Since methacholine is a muscarinic receptor agonist, it triggers bronchoconstriction and worsens obstructive lung disease. That means patients with asthma will experience a much greater drop in FEV1 at a much smaller dose of methacholine than normal patients. For all the details you'll ever want to know about asthma, check out our 3 sketches dedicated to it in the obstructive lung disease chapter. While we're on the subject of obstructive lung disease, let's talk about the other biggie, COPD, embodied by this old man wearing a big, blue, bloated hockey sweater. A patient with COPD is going to present with the 3 cardinal symptoms: dyspnea, represented by that puff of air he's blowing out, cough, and sputum production, represented by that nasty green gunk he's coughing up. Patients with COPD typically have a significant smoking history. We're talking more than 40 pack years here, hence the pack of 40 cigarettes. If your patient presents with one or more of the cardinal symptoms of COPD, your next step should be to order spirometry testing. A patient with COPD will produce an obstructive airflow pattern that does not reverse with administration of inhaled bronchodilators, represented by the non-reversed hat worn by the big blue bloater. Remember what we said about DLCO and asthma? Well, in patients with emphysematous COPD, represented by our recurring sketchy symbol, the pink pufferfish, DLCO will be decreased, reflecting the fact that in emphysema, alveoli are obliterated and no longer able to participate in gas exchange. Hence the clear plastic trash sinking to the bottom of the ocean below the old man. For lots more on the clinical manifestations and management of COPD, be sure to check out our dedicated COPD sketches in the obstructive lung diseases chapter. One last thing. If you have a young patient presenting with the classic symptoms and signs of COPD, especially one without a significant smoking history, consider alpha-1 antitrypsin deficiency. At Sketchy, alpha-1 antitrypsin deficiency is represented by our recurring symbol, the AAT shears, sinking all the way to the bottom of the ocean. Don't worry, we'll talk more about AAT deficiency in our COPD sketch. Make sure to check it out. Now, you might justifiably think that that's it for the obstructive lung diseases. But nope. The third and much less common condition you should know is bronchiectasis, represented by our recurring symbol, the big red pomegranate. Bronchiectasis is characterized by chronic airway inflammation, dilated airways, and impaired secretion clearance. The classic symptoms of bronchiectasis are a chronic cough with daily production of tons, often described as cupfuls, of mucopurulent sputum. Kinda like this nasty green gunky pomegranate. Yuck. Whatever that tree's seen, I don't want to see it. If you suspect bronchiectasis, the first step is to order a chest x-ray, which typically shows dilated and thickened bronchial walls, fluid-filled cystic structures, and irregular peripheral opacities. If you have a young patient with the classic symptoms of bronchiectasis and upper lobe predominant findings on imaging, consider cystic fibrosis, represented here by that thick CF tree sap. CF is the most common cause of bronchiectasis in the U.S. In addition to pulmonary disease, patients are often super thin due to GI malabsorption caused by pancreatic insufficiency. Since cystic fibrosis is primarily a disease of childhood, we'll talk all about CF in our Sketchy Peds course. Stay tuned. Obstructive lung disease is the most common cause of chronic dyspnea, for sure, but that doesn't mean we should ignore the other major type of lung disease. That's right. It's time for restrictive lung disease, in which something restricts the lungs from fully inflating. Just think of this restricted seal caught in that just can't expand its lungs. Restrictive lung disease has many more flavors than obstructive lung disease, but regardless of the specific cause, the unifying signs common to all restrictive lung diseases are the classic PFT findings. In restrictive lung disease, the lungs are restricted from expanding fully, which means total lung capacity, represented by that total load capacity tank, and residual volume, represented by that residual fish tank, are both reduced. FEV1 and FVC are also decreased, but in contrast to obstructive lung disease, the reductions in these values are proportional. Thus, the FEV1 to FVC ratio in restrictive lung disease is usually normal or even elevated. The end result of these reduced lung volumes and flow rates produces a characteristic flow volume loop that's shaped much like a normal one, only much smaller in size. That's why this mound of sand is a lot shorter, but not scooped, compared to our obstructive lung disease sand pile. Let's do a lightning roundup of the major types of restrictive lung disease, starting with the biggie, interstitial lung disease. Interstitial lung disease actually refers to a heterogeneous group of disorders that are classified together because of similar clinical manifestations. In most cases of interstitial lung disease, inflammation of alveolar walls leads to fibroblast activation and collagen deposition, which ultimately results in irreversible fibrosis. Hence the fibrotic-looking lung coral down there. Pulmonary fibrosis distorts lung function and impairs gas exchange, which is why patients become dyspneic. The most common identifiable causes of interstitial lung disease are exposure to occupational or environmental agents such as silica, coal dust, or asbestos, and drug-induced pulmonary toxicity. So make sure to ask your patient for a detailed occupational and medication history. Despite the many different known causes of ILD, though, the most common cause overall is still idiopathic pulmonary fibrosis. Don't remember what IPF is? Head over to our interstitial lung diseases chapter for more details. On chest x-ray, the most common abnormality in interstitial lung disease is a reticular pattern of opacity, especially in the lung bases and periphery, kind of like this reticular net here, stuck way down at the bottom and far corner. Nodular or mixed reticulonodular opacity patterns can also be seen. Remember, though, that chest X-ray findings in ILD are not specific, so if you suspect ILD, your next step should be to order a high-resolution chest CT, represented by our recurring sketchy symbol, the black CT cat. Scuba-ing underwater. Now that's boldly going where no CT cat has gone before. As for why? Yeah, I got nothing for ya. It's a scuba cat.
Scuba cat.
Anywho, the particular findings on chest CT will point you towards a specific cause of ILD. Making scuba cat here our preferred choice for the diagnosis of most types of interstitial lung disease. In most ILDs, DLCO is decreased, reflecting the damage done to the alveolar capillaries. That's why these clear plastic pieces of trash are all the way down at the bottom of the ocean. For more info on the clinical presentation, causes, and management of interstitial lung disease, check out our sketches dedicated to it in the aptly named Interstitial Lung Diseases chapter. Whereas ILDs cause restrictive lung disease by affecting the lungs themselves, disorders extrinsic to the lungs can also produce the same result. What do I mean by that? Well, see that chest wall evoking chest of drawers floating in the ocean? We've put a lock on it to remind you that restriction of the chest wall is another cause of restrictive lung disease. The major chest wall disorders to know include kyphoscoliosis and ankylosing spondylitis. In kyphoscoliosis, the abnormal curvature of the spine, represented by this weird curved spine of the chest of drawers, prevents the chest wall from achieving maximal excursion. This one's pretty easy to diagnose. If you don't immediately see it on physical exam, a routine X-ray will show that classic curvy spine. In ankylosing spondylitis, inflammation of the spinal column leads to fusion of the vertebrae, ultimately resulting in restricted chest wall motion. The classic presentation of ankylosing spondylitis is chronic dyspnea coupled with low back pain in a young male patient. An X-ray in advanced forms of the disease will show the classic bamboo spine fusion of the affected vertebrae. Check out these rocks, covered in muscly, muscles, hanging out by those brittle neuronal starfish. Are you catching my drift right now? That's a recurring sketchy symbol for neuromuscular disease, which causes weakening of the muscles of respiration, again resulting in restrictive lung disease. The major neuromuscular diseases affecting respiration include myasthenia gravis, Lambert-Eaton myasthenic syndrome, Guillain-Barré syndrome, muscular dystrophy, and ALS. We won't get into the details of distinguishing each of the neuromuscular diseases here. That's for a later unit. Instead, let's talk about the one test that can clue you into neuromuscular disease in general as the cause of dyspnea: maximal inspiratory pressures and maximal expiratory pressures. These tests measure the strength of inspiratory and expiratory muscles, respectively. Decreased pressures, represented by that deflated raft with a low pressure gauge, indicate respiratory muscle weakness and should lead you to order more specific testing for neuromuscular disease. For more info on MIPS, MEPS, and the cornucopia of pulmonary function tests you can order, check out our PFT's how-to sketch. Now, the bones and muscles of the chest wall aren't the only extrinsic sources of lung restriction. A small but extremely important space to think about is the pleura, the membranes that cover the lungs and connect them to the chest wall. Long-standing pleural disease, whether it's an effusion, empyema, or scarring, can compress the lung parenchyma underneath, leading to restrictive lung disease. Hence this wet, puffy, red pleural shirt here caught inside the chest of drawers. Like kyphoscoliosis and ankylosing spondylitis, pleural diseases are most commonly diagnosed on chest X-ray. Look for blunting of the costophrenic angle to find pleural effusions, or focal areas of pleural thickening which can clue you into plaques and scarring. For more details on the causes and diagnosis of pleural diseases, check out our pleural effusion DDx sketch. Lastly, we should address a fast-rising cause of restrictive lung disease: obesity. Too fat to breathe may sound harsh, but that's kind of what happens. Just like that rotund seal caught in the fisherman's net. Excessive extrathoracic soft tissue, like that layer of seal blubber, compresses the chest and limits expansion of the lungs. Eventually, there's just too much weight for the respiratory muscles to overcome, and boom, you've got restrictive lung disease on your hands. Hooray! With restrictive lung diseases behind us, let's move on to the other pulmonary causes of chronic dyspnea that fall outside the realm of obstructive and restrictive lung disease. See that fish pulling on that pulmonary seaweed, building up the tension? At Sketchy, those tense pulmonary vessels can only mean one thing: pulmonary hypertension. Pulmonary hypertension causes chronic dyspnea by increasing resistance in the pulmonary vasculature so much that it becomes difficult for the right ventricle to pump blood through the lungs. Pulmonary hypertension can result from primary pulmonary arterial hypertension, represented by the tense red pulmonary seaweed, or chronic thromboembolic disease, represented by the buildup of those cute little thrombotic sea cucumbers. Trust me, they're not as fun in real life. Because the early symptoms of pulmonary hypertension, exertional dyspnea, and fatigue are nonspecific, early diagnosis can be difficult. Typically, the diagnosis isn't made until much later, once severe disease has led to right-sided heart failure. If you suspect pulmonary hypertension, an echocardiogram is the diagnostic test of choice and should be your next step. An echo, represented by our recurring sketchy symbol, the echo megaphone, can estimate pulmonary artery pressures and see if right ventricular dysfunction is present. For more details on the presentation and management of pulmonary hypertension, check out our dedicated sketch on it later in this unit. Meanwhile, up there on the pier is a crab catcher with his cage full of cancer crabs. You know what that means. Lung cancer can cause chronic dyspnea in a number of ways. Airway obstruction for mass effect, infiltration of functional lung tissue, and bleeding from the tumor into alveoli are just a few examples. Patients with chronic dyspnea and other concerning details like age over 50, significant smoking history, and weight loss should be evaluated for malignancy with a chest X-ray, which will classically reveal a solitary nodule or mass lesion. Last but not least, the cactus behind that crabby crabber should remind you of chronic exotic lung infections such as tuberculosis, non-tuberculosis mycobacterial infections, nocardiosis, and fungal infections. These exotic infections often show up on chest X-ray as cavitary lung lesions, represented by the cavitations in the pokey cactus. How that cactus ended up on this pier is anyone's guess. It's almost as confusing as scuba cat. Scuba cat! Check out our pneumonia in special population sketch for more details on these and other exotic lung infections. Finally, let's leave the lungs behind and dive into the final category of causes of chronic dyspnea, cardiovascular. To start off, heart failure is a big cause of chronic dyspnea, rivaling obstructive lung diseases as one of the most common causes overall. In heart failure, the lungs work just fine, but the heart's impaired pumping ability causes fluid to back up into the lungs. To represent heart failure, we're bringing back the #1 threat to endangered species across the globe, our recurring sketchy floppy heart balloon, which has gotten snagged on our poor seal friend here. Womp womp. Shad fish. Anyways, when you see that floppy heart balloon, you should think back to the various conditions we covered in our heart failure sketches. Oh, what? You haven't watched them yet? Well, what are you waiting for? An invitation? Oh, okay. We cordially invite you to go check out our sketches on heart failure once you're done here. Well, there you go. Now you have to show up. Patients with heart failure should have other classic signs on exam, like bibasilar crackles from pulmonary edema, represented by those strips of crackly Velcro, an S3 gallop, represented by our recurring S3 slushies, and an elevated JVP, represented by those big blue jug-like sea sponges. If you suspect heart failure as the cause of your patient's chronic dyspnea, order a BMP, which should be elevated, usually above 400 picograms per milliliter. That's why the tail fins of this BMP blimpfish look like the number 400. On chest X-ray, patients with heart failure may have findings like cardiomegaly, pulmonary vascular congestion, and bilateral pleural effusions. The most important diagnostic tool for heart failure, however, is the echocardiogram. In addition to diagnosing systolic and diastolic dysfunction, the echo can also point out potential etiologies of heart failure, such as valvular disease, pericardial disease, or pulmonary hypertension. By now, you've probably understood the common theme of this sketch. The history and physical will significantly narrow your differential and determine the specific tests you should order next. However, if your clinical evaluation of the patient isn't producing much fruit, there's one helpful lab test you should order: a hemoglobin and hematocrit to look for chronic anemia. At Sketchy, H&H is represented by our recurring symbol, the red abacus. To represent anemia, let's sketch in a few anemic-looking anemones, suspiciously surrounding that one red anemone. I'd get the hell out of there if I were you, red anemone. Anemia can cause dyspnea, usually on exertion, by decreasing the oxygen-carrying capacity of blood. Chronic dyspnea is caused by chronic anemia, which typically results from slow, undetectable bleeding like the occult GI bleeding from gastritis or colon cancer. Generally, anemia has to be pretty severe before patients experience symptoms, but that can depend on the degree of exertion that the patient undertakes. Either way, an H&H is fast, inexpensive, and will help you figure out if anemia is playing a role in your patient's symptoms. Alright, let's finish up with the review of the workup for chronic dyspnea. The majority of patients with chronic dyspnea of unclear etiology have one of 5 diagnoses: asthma, COPD, interstitial lung disease, heart failure, or obesity. As you can imagine, the clinical manifestations of these diseases are pretty distinct from each other, so your history and physical will go far in pointing you towards the likely diagnosis and giving you a short list of the pertinent tests to order. If the clinical evaluation doesn't narrow the differential, however, there are a few high-yield tests that you can order. First, an H&H is a quick and cheap way to exclude chronic anemia, a relatively common cause of dyspnea by virtue of its prevalence. Next, a chest X-ray can reveal all sorts of potential pulmonary, cardiac, and thoracic causes of chronic dyspnea. It might not tell you exactly what's going on, but it will help point your testing in the right direction. If that still doesn't bring up any clues, your next stop should be the Pulm Lab for a full set of PFTs. Spirometry, lung volumes, DLCO, and MIPS and MAPS will help you decide if obstructive or restrictive lung disease is playing a role in your patient's symptoms. If the patient's lung function is normal, then it's time to look at the heart. A BNP, followed by echocardiography, will help you diagnose the vast majority of cardiac conditions that can cause chronic dyspnea. And that's about it. Make sure to check out our sketches dedicated to the conditions we've discussed here for more details on those particular disease processes. Coming up, we'll go through the differential diagnosis of everyone's favorite vital sign abnormality, hypoxemia.